So our next presentation is going to be from that category of integrated health systems that we showed before, which is kind of regional and really focuses on population health improvement. It includes a lot of commercially insured patients. Our next speaker is Dr. Wellesley Chapman, who's a family physician. He's currently the medical director for innovation and business development at Group Health here in Seattle. Which, if you're not from here, I hope you know is one of the leading integrated health systems in the country. It was interesting because several of the presenters so far showed themselves as being in the 90th percentile of various measures, as is Group Health in a number of these measures. So you really are getting the cream of the crop of American healthcare as measured externally at least. Wellesley has been at Group Health since 2008. He then rose through the ranks to become a clinic medical director chief, medical center chief, and a lean consultant prior to leading the innovation team. Today he's going to talk to us about one of the transformation models. You've heard it referred to already, the patient-centered medical home, and some other elements of Group Health systems. So Wellesley?
Thank you. Welcome back, everybody. So welcome to the next category. And I'll tell you, so we've heard a lot about a lot of really hard work here. And one thing that's really hard is following these morning speakers. Some really, really amazing stuff. So I'm going to do my best. And you will notice some repetition here, because it's good to know that we have not all arrived at independent conclusions about what good looks like. So I'm going to tell you about the medical home. A little introduction. So Jonathan kindly introduced me. For the last 3.5 years, I've been working with a brilliant business partner, Elizabeth Fleming, on an innovation team. We are a small innovation team. That seems to be the flavor. Either innovation teams have 3 people, like ours, or 30 people. We got the smaller variety. And our job is really to work on new business models within Group Health, right? Within a large integrated system. And so that's what we do. So what I want to do today is tell you a story about a health system that had lost its way and found its way, and maybe lost its way a little bit. And you will hear some really familiar themes from the morning. And then I want to end on a cautionary note. And I think that's where I'm hoping to add some value today to these brilliant speakers from this morning. So here's Group Health. So Group Health was established in 1947 as a cooperative. A bunch of patients who were fed up with the system, with access and cost and getting the runaround, hired some doctors to take care of them. And so that was the model, fairly simple. We are now, however many years later, we still have patients who will bring in their founder card and say, I have been here since the beginning. There are many, many people who have memorized their member number and who will tell you exactly in which Group Health facility they were born. Right, so it's really, really deep in the community. We combine care and coverage. We are a health plan and a care delivery system. We currently care for about 630,000 patients. We have about 26 medical centers. We have 0 hospitals. We have recently gotten out of the hospital business. We are built around prepayment. So that first notion, those patients hiring doctors to take care of them, remains, right? So we are a total cost of care system. We get paid up front. Our physicians are on a salary model. So seeing one more patient or doing one more colonoscopy does not result in any additional revenue. So we believe that we are aligned with our patients. I love that who was calling them? They're customers, right? Those are your customer owners, right? We have customer members, and that's really powerful language, I think. So we have aligned our customer member with our provider with the financing mechanism. So that's a great system, right? That should work. That should work. You've taken the perversity out of the system, and we were doing really well for a really long time. In the early 2000s, we ran into a problem where we had burnout, we had quality problems, we had decreasing enrollment, and we wondered what to do about that. So we said, let's try something completely different. Let's take one clinic, it's our Factoria clinic, which is just across Lake Washington, about 15 miles from here, and said, we're going to lavish resources on you. And we are going to set up some predetermined outcomes around quality, around burnout, around member experience, and we're going to see what it takes to improve those things. So we went deep into that and brought in the Group Health Research Institute and the McCall Center. We brought in our lean process improvement team and spent 2 years working with this group. And this group really redesigned their care. really redesigned this. One clinic really redesigned care. What I want to tell you about is what was the stuff that worked? What was the stuff that worked? So one of the outcomes of that experiment, that 2-year experiment, was this, Health Affairs, May 2010. I am not here to present to you a 6-year-old publication. But what we learned here really still forms the foundation, the chassis of how we deliver care. So what we found there is that we had better engagement, better patient engagement, better staff engagement, better quality, and lower costs. And so I won't go into the details of this, but I want to tell you about what the elements were. So the first one, and this is the first really familiar piece of information, is that success really is about the team. Success is about the people who are delivering care, right? It's about your patient, your customer, your member, your owner. But without really investing in your team, you don't have much. So we said this is going to be really primary care oriented. The care that is delivered, that is where you begin your care. Hopefully, that's where you end your care. I was trained to believe that I could care for 95% of what walked through the door. We have interdisciplinary teams. We have physicians. We have PAs. We have some nurse practitioners. Mostly, it's a physician-PA model. RNs, clinical pharmacists on the team, in the team, and medical assistants. And that specialty, so we are an integrated group practice. We have about 1,000 physicians. And about half of those are primary care physicians. So when I came out of residency, I had grown accustomed to having a preceptor outside the door who I could consult, and I was terrified going into practice that I wouldn't have that anymore. But I have about 1,000 consultants that I can get a hold of very, very quickly. Specialty is really there to support primary care. And then coordination through the EMR. We are an Epic shop, so like many others, but we are highly coordinated through our EMR. One of the functions that we found really essential, so in 2001, we opened up secure messaging to our patients, right? At the time, that was really revolutionary. Some people said, hey, so we've been communicating for about 2 decades with one another with this thing called email, but that seemed to be foreign to healthcare. So we launched that in 2001, and that really was revolutionary and started to transform the way we deliver care. So multiple access channels. Yes, you can come in face-to-face. Yes, you can call us, and we had scheduled phone visits. Or you could call. We have a phone system set up that if I push the button, I could actually get a call from my patient. That was almost unheard of, and patients generally didn't believe that their physician had just answered the phone. And then secure messaging. So different access channels. And so right now, we do about 2/3 of our care virtually. About 2/3 of our total care is done virtually by telephone or secure messaging. Chronic disease management, right? So this is the bulk of the work of the family physician. The bulk of the work of the family physician is taking care of people who have heart failure and diabetes and COPD and asthma and coronary artery disease and who need a lot of help in managing those things. Those are progressive diseases, and generally there's a lot of change that goes on in those things. So we really took a team approach. We had some templated care plans that we experimented with for quite some time to say, hey, look, so here's a CHF treatment plan. Here's a diabetes treatment plan. We had a whole lot of different treatment plans. It's good to hear about some unified treatment plans. And then standing orders, right? So I had a great clinical pharmacist, Shannon, in my clinic, and she would just go treat somebody to target with their diabetes, with their blood pressure, and I knew that she was in good hands. I knew that my patients were in good hands. I knew that they would get great care, and that Shannon, who was very creative, would recognize when she was off protocol and come up with a solution and bring that back to me. And having those solutions teed up really, really helps patients, and and she was able to invest in relationship in a way that I really wasn't. So clinical pharmacists treating to target, and then support staff outreach. So we make robust use of registries. It's something I've heard a little about today, but registry is a really important function. So support staff outreach, so all day long, finding those folks who are at risk, however we were defining risk, finding those folks who are at risk and helping to bring them in. Population management. So most of the language around population management at group health seems to flow out of our health plan. We have this notion that there are these different personas, and the best we could hope for from a patient is that they become what we call a lifelong believer, right? That they are someone who exercises, who eats well, who takes care of their soul, who takes their medicine, who gets their preventive care done, who really monitors how they're doing, has active community, right? And that those folks have the best health outcomes. And so all we can hope for as a health plan is to move folks to there. We also have a care delivery system that aligns around that. And the thing that we have in healthcare that most other industries don't have, and it's the thing I think we squander most frequently, is a one-to-one relationship with our customer, right? If Coca-Cola had that, if Disney had that, I think they would be even more unstoppable than they are. We have one-to-one relationships, human relationships with our customers, and I think we don't fully take advantage of that. So, but one of the things we do is to take that population approach and bring it right down to the individual, right? And mostly that's through opportunistic care. You're here with me. Let's talk about your risk. Let's talk about how we take care of you. And management systems, right? So this is where I started to get really sort of geeked out and happy in my work around leadership, was around management systems, and particularly lean management systems and visual management systems. So how do you recognize if something's working or not working? What do you measure, and how can you easily see that? So we built this very, very complex system of management tools around access and quality. We had tier boards. There's a board right in front of me where I'm working all day that has information that's useful to my team that tells a story, and we go up and write on that board. We have control of that board, and that tells an important story. We have boards that tell a story, that aggregate that at a clinic level, and then that rolls up to a regional level or a systems level. It aggregates then across primary care and specialty to let us know if we're hitting our targets. Anybody get nervous thinking about that? I get a little nervous thinking about that. But, and then that enables us to see where there is some risk in our function, in our operations, and then to try to understand that, to really go after that with some good lean approaches. So I moved pretty quickly through that. I feel like my task here today is to render some advice. I don't think I've given you advice that's any better than what you've already heard. So here's what I'm going to do. I think you deserve good advice. So in order to give you good advice, I want to tell you a cautionary tale. Because the outcome of this work that we did at Factoria and spread across 26 medical centers produced a lot of good results. Medicare 5-star, NCQA accolades, Medical Group Management Association accolades, lots and lots of good things. But in many ways, we find ourselves back in the same place in 2016. We have burnout. Our quality measures are struggling. They're not quite what they were. So how do you sustain, right? And these are the questions that we're asking ourselves. So it's a messy, messy business. And so the thing that I heard that I want to share this morning, I heard it multiple times, was about relationship. It was about relationship. So, and I want to talk about relationship in 3 ways. And I'm assuming I'm OK on time. All right. So the first is around spread. We built this clinic in one place, invested heavily over 2 years, and then said, this is great. We want to spread this across multiple locations. And I was a medical center chief, and it was my job to take the things that had worked at Factoria and make them work at Burien, a clinic about the same size, with a very different population, a very different physical sort of layout. And how was I going to make that work? And so that showed up for me as playbooks, 100-page playbooks. And I would get them, and I would pour through them, and I would pull out the 2 or 3 pages that felt relevant, and then I'd try to sell it to a group of 13 doctors. So the thing that I learned about that is that autonomy matters, right? The thing that that Factoria group had that was so special was they built that. They built that. They owned it. They loved it. It was really important to them. So autonomy matters. And I think people felt like, I don't have much autonomy in this. You're telling me how to run my practice. And independently, they would have come up with the same thing. But when you give it to them, right, you learn hard lessons about trying to give people the truth. Culture too. Culture will eat a 100-page guidebook for lunch and then come back for more. So we ran through a lot of guidebooks with culture chewing them up. So how do you invest in people? How do you invest in your teams so that they really feel ownership of the work that they're doing? The second is around really understanding who your customer is. So who is your customer? Who's your customer, member, owner, patient? That's your customer. It is so easy in this work to start to think of NCQA as your customer, right? And start designing the work specifically to hit those goals. When you design your work to hit those goals, you probably aren't going to go a whole lot deeper. When all of your resources are focused on hitting what you believe are the most important things, 90th percentile HEDIS around 5 measures because that's going to get us 5-star. That's hard. That's really hard. It's hard to hear. It's not inspiring to teams. It certainly has nothing to do with how a patient thinks about quality. And so there's a real risk there. There's a real risk. So think about who your customer is and think about who they aren't and design for them. And the third, and I think this is the most important because it seems to be the hardest right now, is time. So all of the things that we heard about, all the transformations that we've heard about today took time, right? You had to invest time in people. You had to invest time in relationships. Have you ever, with your spouse or your children, when they are upset, tried to be efficient about that? Right? How does that go? Right? Being efficient with emotion is really hard. And change is all about emotion. So change in systems, change in a clinic, change with patients is really hard, and really understanding them. So even in a system like ours, we're a total cost of care system. And still, we define that unit of productivity as the visit. It's kind of hard to think that way. And we do it because people call us and say, I want to visit. And we're geared to respond in that way. And we say, hey, we have a phone visit, we have an in-person visit, we have secure messaging. But we haven't really come up with those systems that allow us to think differently about time. We've got to invest time. And that's just a hard thing to do. Okay. So I don't have solutions for you. The entirety of my day, every day on the innovation team is thinking about how to solve these things, is thinking about how to invest differently, at looking at our system, which is a great system. It's a competent system. It does what it's supposed to do most of the time, and people understand their work. That's essential. But we have constraints. We've built-in constraints. We've built-in constraints about place. We've built-in constraints about who does the work. We've built-in constraints about what an email looks like and who should respond to it. And we built in constraints about where the work happens. Does it happen in a clinic building all the time? And I think what we do on our team is try to redefine those constraints or challenge those constraints systematically to say, what if we took away time? Would we learn more about a patient if we took away time? What if we went and visited them at home? Would we learn more about them? The answer is yes. You learn a ton more about people when you go enter their lives. And the people who show up for a visit when you go to their home is pretty outstanding. It's pretty amazing. You learn so very much. So that's the work that we do. That's the work that my team does. We do that in low-risk populations around easy access models, quick care. We do, quick care was you. We do that work right now around high-risk populations, vulnerable populations, embedded in primary care, being of primary care, but without those usual constraints that primary care lives with. And we believe that that's the right work, that we're going to have much better outcomes, and ultimately be able to invest the kind of time that is needed to build relationships, both with our patients, but with teams too, so that they start to feel engaged and own that work. So I'll talk a little bit more about that in 2 breakout sessions later this afternoon, but I will stop there, and thank you.